Good afternoon, everyone. We're just going to give everyone a minute to join us, and then we'll get on with today's program. All right, good afternoon, everyone, and thank you for joining us here with the National Native Network for today's webinar on hepatitis C in Indian country screening, treatment, and support, and live TA for RPMS and iCare users. I'd like to welcome our speakers, Brig Riley, epidemiologist from the National HIV HCV program, Northwest Portland Area Indian Health Board, Dr. Nicholas Cushman, pharmacist for the Indian Country ECHO and Northwest Portland Area Indian Health Board, Dr. Carolyn Chu, MD, MSc, PI, and Chief Clinical Officer for the National Clinician Consultation Center, University of California, San Francisco, James Spillane, Clinical Applications Improvement Advisor from Health IQ, and Kristen Haley, Clinical Applications Coordinator from the Little Traverse Bay Bands of Ottawa Indians. Today we are going to have a panel and moderated discussion, and following the Q&A, after our presentations from Brig Riley, Dr. Chu, and Dr. Cushman, we will have the technical and training assistance from James Spillane and Kristen Haley. So for now, I welcome all of you, and I'll turn it over to Dr. Cushman. Dr. Cushman.
Great, so I'll go ahead and jump in, Nick. Do you want me to do the first? I'm gonna, good afternoon, everyone. So I'm gonna go ahead and do about 7 minutes on kind of an intro to Hep C from an epidemiology and screening perspective, and then we'll get into treatment and then the technical support. So next slide, please. As you can see, Nick and I are good at quite some things. Formatting PowerPoints is not one of them, so it's super straightforward here, just black and white. We've got some graphics, don't worry, it gets a bit better. I do want to point out that it's a common disease. It is the leading cause of hepatocellular carcinoma and liver transplants, and millions of people have it. And there is a big disparity in American Indian Alaska Native mortality rates related to Hep C. It's coming down now with treatment, but not nearly as fast as other groups. It really is a question of access, because once this is treated, pretty much all these negative effects go away. But I was working in HIV, and as an example, I think we have about 3,000 persons in the ITU system with HIV diagnosis. It's north of 40,000 for hepatitis C. So by far, for most sites, somewhere between 10 and 100 times more persons with Hep C. So it's really become our priority nationally. Next slide, please. This is an old slide, but the point is made sort of as hepatitis C. A lot of people were exposed to the virus many years ago and did not know it. It has no symptoms. It builds over time. And then this mortality wave started to grow as the long-term damage became manifest in the form of cirrhosis and other complications. And if you combine all the other diseases that are reported to, so this includes TB and HIV, those declined mostly with biomedical interventions and prevention, but hepatitis C began to climb and actually surpassed all of those combined. 2012 is when it just started to bend down because, well, 2012, we had the first direct acting antivirals, which you'll hear from Nick have made all the difference and started to, as we got into 2018 and 2019, started to really make a difference because that became more widely available. Next slide, please. So this is just a very simplified overview of the progression of disease. There are, after exposure, A majority of patients will develop chronic hepatitis. Some will self-clear the virus, so there will be a confirmation step that we do in our testing. But untreated, it will often progress to cirrhosis and then end-stage liver disease and death. So this is really what we want to prevent, it's really changed from where we used to be on hepatitis C. It used to be very complex and hard to treat, and that's completely changed now. Next slide, please. So this is from CDC. They basically thought that most people, in their estimation, had no idea they had hepatitis C on board. Again, no symptoms, not really realizing they might have been exposed to it through either injecting drug use or a blood transfusion before there was widespread Hep C testing. So there's a lot of people who don't know that they have Hep C on board and no clear risk factors. And this is part of what underpinned the screening recommendation. I heard of one situation in the Southwest where someone in her late 60s basically was diagnosed with esophageal varices, so very late stage disease, discovered she had late stage hepatitis C driving all of these conditions, and she was able to be cured happily. But that is just an example of if we don't find it early, it sometimes can manifest itself in patients who we do not expect at a very late stage. Next slide, please. So this is, give me a second here. This is a bit of a busy slide. First, we want to follow the blue bars. The blue bars is when in 2012, you see on the far left, the US Preventive Services Task Force said, hey, there is so much Hep C, the new drugs are so good, and untreated hepatitis C is so bad for our patients' outcome, we're going to screen everybody between the ages of 1945 and 1965. If you're born in those years, we just see a big epidemiological spike in how many people have chronic hepatitis. We can just guess why maybe another time. So this is what we have from IHS. They had started in 2012, only 8% coverage of screening. And within a few years, they got it over half the patients screened. So they would really quickly once this recommendation went out. If now I switch to those red bars, the hepatitis C, again, the treatments got so good, they're finding so much disease that they just said, you know what, we need to screen everybody. So this became a national recommendation as of 2019. Still hasn't really taken off. It started up high because so many people were captured in the birth cohort screening or prenatal screening, but you can see it's still struggling to get traction. I think a lot of that is on the background of COVID. Next slide, please. So it's pretty straightforward. The sites that we see that are screening really well, they have a policy, they have some standing protocols. So it's not just dependent on the provider, and they use often a reminder in their EHR to say, hey, this person has not been screened, but they're eligible. Don't forget to do that. You don't have to create your own template or policy from scratch. We have some examples that if you want to do something locally, you can easily modify it for your situation. Next slide, please. This is what we have on statistics for Bemidji area. These are IHS data from our National Data Warehouse. So each year here is how many new patients are being diagnosed per year. You can see from 05 to about 2011, just about 100 or north of 100. And then we kind of have a big chunk probably where screening really happened. And then again, we're still seeing above 150 new diagnoses just in Bemidji area per year. Next slide, please. Now, these patients, if we talk about each year and we add them up, we all of a sudden, we get more than 2,000 patients with an Hep C diagnosis since 2005. So that is a lot of people, and this is just the data we're picking up. And if we screen more, we're going to find a lot more. So the actual burden of hepatitis C is notable. Next slide, please. And this is my last slide. You can look at the first red oval. So this is the incidence. So how many new patients per population among American Indian Alaska Natives in Michigan. This is from the Michigan Department of Health from 2016 to 2020. As you can see, as you read across in 2016, it's 149 per 100,000 new diagnoses of Hep C. And you go over to that second oval and it is 73. So more than twice. It is both the highest of any race ethnicity in Michigan and more than twice that of whites. If you go down over the years, that's pretty much a consistent pattern. the new diagnoses kind of fall off a cliff in 2019, 2020, but I think that's a testing artifact because it happens in every group when there's no really good reason. Bottom line is it's very much in Native communities. And I think that takes us then to Nick, sort of, if we're going to screen, what are we going to do about it?
All right, thank you, Brig. Hi, everyone. As Beth mentioned, I'm Nicholas Cushman. I'm an enrolled member of the Sioux tribe, born and raised. As you can see, the government makes it pretty easy to get dressed every day, as I'm also a public health officer. I've spent several years in the Southwest and Pacific Northwest in a variety of roles, staff pharmacist, chief pharmacist, and now more kind of a clinical programs coordinator role. One silver lining to the pandemic was I was able to return back to Michigan and where I work completely remotely here. So switching gears, we're going to talk treatment options and available services to support your facility, your staff, and the relative ease to treating Hep C in the direct-acting antiviral or DAA era. So ITU facilities face provider shortages and specialists are scarce. We know this, given prior interferon-based treatments were complicated with significant monitoring requirements. The standard of care back then was to receive Hep C treatment by a liver or ID specialist. Considering the US as a whole, there's an estimated 20,000 specialists for over 3 million chronically infected Americans. Add on the fact that specialty care is costly to our system, often limits access, continuity of care with extended wait time, schedule inflexibility, and often long travel time. This disparity is even more amplified within our Indigenous communities. Therefore, with expanding the ease of therapy with DAAs and minimal contraindications, monitoring requirements to care, our attention should and has already begun to rely on primary care providers to fill this vital role. Physicians, mid-level providers, and especially pharmacists. Usually we're focused on managing disease states, but with Hep C, we're talking about curing. And that's measured by an individual experience sustained virological response, or SVR, at 12 weeks post-treatment. And unsurprisingly, this is associated with significant reduction in liver cancer, liver failure, and all-cause mortality. Not to mention the cost savings on the health system by preventing further complications and even working towards community elimination. So again, treatment with DAAs is relatively simple. We're usually talking Mavyret or Epclusa, as both are pan-genotypic options with low pill burden, either one pill daily or 3 pills daily with food, and a treatment duration of 8 to 12 weeks. They're both generally well tolerated, with headache and fatigue being some of the more common side effects. And they're demonstrating SVR12 at rates greater than 90%. We also have Harvoni. All three have been added to the IHS National Core Formulary in an effort to minimize costs while increasing patient access for our populations. There's also patient assistance programs available, and our network is knowledgeable and available to support getting those approved. And then one last note, there are several drug-drug interaction considerations. We're talking acid suppressive medications, statins, anticonvulsants, DOACs, ethinyl estradiol products for Mavyret, and then antiretrovirals, to name a few. But the University of Liverpool has developed a wonderful interaction checker tool that provides more information and recommendations, and that's available on the link on the slide. So as I mentioned, many ITU facilities are already relying on primary care providers, especially pharmacists, as we tend to be a little better staffed to step up and fill this role. Obviously, I'm a little biased, but it's well documented that pharmacists are readily accessible and able to successfully meet these clinical needs. Belcourt IHS is one great example of a pharmacy department exceeding in this role, as noted in the Pharmacy Today article. There's several other examples of pharmacists and pharmacy departments leading the charge within their facilities and communities. I want to highlight Dr. Whitney Dixon in the Bemidji area at Cass Lake IHS, who's just done an amazing job starting a Hep C program from scratch, and is another great source of knowledge and experience within our network that's available. So these are some of the available services from our network, from Indian Country Echo, from IHS, from the warm line that you'll hear Dr. Chu speak about. And myself personally, being located in Michigan makes this even easier, as I'm more readily available to come in person or meet virtually to offer these services. We're able to support a facility starting from the beginning by anything from defining a patient panel through iCare and helping to prioritize them. We're able to offer clinical training with content and audience defined by you based on your needs. We're able to connect you with specialists for mentorship, guidance. We're able to assist with medication reimbursement. Of note, many of our sites that start hepatitis C programs do experience significant cost recovery. And we also have the capacity to support via telehealth or our echo sessions where one has the opportunity to present their patient cases to our faculty and have the ability to ask questions, further discuss, and receive formal written treatment recommendations and support moving forward. And then we have teleconsultation options as well, and you'll hear more about that shortly. And then, of course, they're all available at no cost. So additionally, we have an abundance of indigenous designed and developed materials and resources, both for community and clinical members. We're always more than happy to ship some of these to your facility, or they're always available at our website, indiancountryecho.org as well. So my final message in this brief overview, talking to Hep C, is that it starts with just one patient, one individual, one community member, and we understand that anything new is going to be a slow process and may seem overwhelming at first, but our goal is to really support you, connect you with enough mentors, resources, whatever that may be, to get you feeling comfortable and confident to sustain a lasting program or service, and one that really impacts your community and patient population. So I'll leave you with our contact information. Please don't hesitate to contact us. This is really our bread and butter. It's awesome being back in Michigan, around family, friends, and now in a position to really support not only my tribe, but all of the tribes here. And I genuinely hope to establish a connection with all of you. We do, just as a note, we do beyond Hep C, we offer these same services for substance use disorders, sexually transmitted infections, HIV, PrEP, PEP, really you name it. So if you have an area of interest, please reach out, and we'd be more than happy to help you establish that, to further develop it, whatever that may be. Now I'm going to turn it over to Dr. Chu to talk about the warm line. McGwitch.
Great. Thank you so much, Nick. And I couldn't have asked to follow a kinder and more inspiring group of presenters. And I just want to offer a real genuine thank you to our host today for allowing us to share some time with you this important meeting. Let me go ahead and start my slides. Are they working? Yes, great, thanks. So as Nick and mentioned and Beth earlier on, I am here to just share information about the warm line, as we're referred to, but we basically sort of operate through a teleconsultation model that we really try to hold out as being very accessible. You don't need any fancy equipment. What you just need is a phone to be able to reach out and connect with the human being, one of our consultants. And I think I just want to try and impress that. we are in a information overload era, and EHRs are magical in many ways, but sometimes the guidelines don't necessarily, talk to every single specific scenario that you might encounter in your practice, or, you might be looking for some information that may or may not necessarily be in an order set or template. And I think that's kind of the space that we try to fill, to be able to just sort of lend a human ear, some clinical experience to help folks sort of navigate some, real world treatment decisions. So I don't have a ton of slides today. I'm just going to really sort of describe, who we are, what we do. I'll leave you all with my email, and folks are welcome to reach out if they have any additional questions. So just to sort of back up and describe a little bit about our history. So that is a aerial shot of San Francisco General Hospital. It's a city county hospital. So sort of pre-COVID, we all operated out of our call center. At this point, our team is able to, still do their consultation work with us remotely. And so we have also, sort of enjoyed this telehealth era where we can still, show up and hopefully be of service to patients and communities and providers. But we're not limited to sort of being in one physical space anymore. We've been around for almost 30 years. As you can see there at the top, we were sort of formally established in 1993. Our work had historically really been focused on HIV, but given, I think, just the sort of evolving public health sort of, ID related epidemics that we have all seen, transpire over the years, we've actually expanded our scope. And so we do take hepatitis C related calls. So that's our Hep C warm line. And then, as Nick mentioned earlier, substance use, overlaps a lot. And so we also offer a substance use consultation service as well. And that's just a oldie but goodie photo to sort of highlight sort of where we were then and maybe where we are now. I think overall we've really tried to stay very true to our philosophy that, as Nick mentioned, specialists can be sometimes really hard to reach. I think especially with the pandemic, so many of at least our local ID folks were really deployed to COVID. We've seen a huge shift of folks sort of entering or recently retiring, and I think that's left a real gap in some of the access to specialists. And more importantly, as Nick mentioned, also, with Hep C and the DAAs, this can absolutely be done in primary care. And I think we are also fully supportive of Hep C treatment occurring in primary care as well. We're free. That's part of our sort of low barrier threshold to be able to reach someone on our team. And folks are welcome to reach out as often as you would like. I should emphasize that we are a provider facing service, so we are unable to accept calls from patients. But basically, if you identify as someone who is a healthcare professional, so no matter what role you play, whether you're a prescriber or non-prescriber, but helping out with adherence, care coordination, we are more than happy to speak with anyone who is part of this person's care. I think another note that I might just emphasize is we do not ask for any PHI. We are very much an educational resource, and so we are not looking into charts. We're not asking for patient names or identifiers or anything like that. We keep our consultation notes just sort of organized by the name of the provider that we speak with, and at this point we are trying to follow the digital curve, and you can certainly call us, and by far that's how most of the consultation requests come in. But if you do navigate to our website, we have a way that you can sort of create a provider portal account and sort of send in your query electronically, and it just feeds directly. And so our team will see it and get back to you at your convenience. And ultimately, as I was sort of mentioning before, we really try to make the information that we share very practical and sort of immediately actionable. So if you call us around, should I initiate Hep C treatment for this person? Or gosh, this person didn't pick up their second month of meds and now I'm worried that they might have a gap. What should I do? Sometimes these are time sensitive decisions that you just want to make sure you're sort of doing the best by your patient, and every case is so different. So I think that's where we come in. I just wanted to sort of highlight some of the faces of folks that you might speak with if you were to call, and if you can sort of see the rose-colored sort of squares, those are the folks that pick up on our Hep C warm line. Dr. Gruda, I think, was on earlier today. She's one of our pharmacists. We also are totally biased and love pharmacists. We've got two amazing, highly experienced Hep C pharmacists that take our Hep C warm line calls as well. And just to, as I try to wrap up, I thought it could be helpful to share examples of calls that or questions that we've specifically received on our Hep C warm line. So as I mentioned earlier, treatment access and initiation and missed doses or abbreviated treatment courses, I would say that by far that is probably one of the most commonly asked questions that we get. I will note that the guidelines have now offered some information, but for many, many years, the guidelines really didn't tell us what to do in cases of sort of missed doses. We are big fans of the simplified Hep C algorithms, but sometimes you might have a question about, does this person sort of fit into that bucket, or what else should I be thinking about? We've also gotten those calls. Of particular interest to me, I think, is Hep C and women's health. This might have some overlap with some of the sort of substance use epidemiology that we're seeing, but certainly pregnancy and breastfeeding to me feels like an area probably that's worth sort of paying a little bit more attention to, because we don't have a ton of data on sort of safety and use of the DAs in pregnant people. I'm not going to sort of belabor too much what's on this point, but just as Nick mentioned earlier, we try to be a one-stop shop. And so, not only do we take calls around hepatitis C, but also HIV prevention, treatment, substance use, and all the toll-free hotline numbers that we operate are absolutely free. So here are the numbers. And I'm so proud of myself. I created a QR code and it works. So if folks are inclined and have those like ubiquitous QR scanners, if you want to scan that, I'd be thrilled, personally delighted, and it will take you to our homepage. And if you're someone who has your cell phone on with you all the time in clinic, you can actually call us from a cell phone. We've got it programmed that way. So if you go to our website and you hit the orange button, you can actually call a line right then and there from your cell phone. So absolutely welcome any and all questions. And again, thank you so much for letting us be a part of today.
Thank you, Dr. Chu, Dr. Cushman, and Brig. We did have one question that Brig answered, but if you'd like to talk about this verbally here for a moment, what contributed to the decline in incident rates from 2018 to 2019? Brig, I'll let you go first.
Yeah, I put in basically fancy words for saying I'm not sure. But one thing I would say it's probably a function of testing. What we had between 1945 and 1965, when we started screening in 2012, we were picking up a lot of historical infections. These were patients who generally had been exposed to the virus 20, 30 years ago, and we were just catching up with that diagnosis. So they were new diagnoses, but not new cases. Then in 2019, between learning more about Hep C and how widespread it was, and kind of a new wave of infections that we're seeing among younger patients, largely driven by injecting drug use, then we're picking up a lot more, one, with universal screening happening, and two, with a new wave of new infections. So my speculation is that 2018, 2019, because we can't blame it on COVID yet, right? That they stopped screening yet. If I were to talk from IHS, I would say a lot of sites had already saturated their screening of the birth cohort. As you saw, although we were only at about 50%, what that usually means the site has really tested everyone in primary care, because we're really good at testing when they come through that door, but not very good for screening when they come through another door. So we probably found, at least for IHS, a lot of our baby boomer diagnoses, and we had not yet transitioned to wider screening that then kicked off in 2019. So maybe those years that the question was about, maybe that was some transition years in testing patterns.
Thank you, Brig. Again, if anyone has any questions for Dr. Chu, she has to depart early for clinical. So if anyone has any questions for Dr. Chu, we'll give you a few seconds here while I introduce you to James Spillane and Kristen Haley. James and Kristen are going to support some demonstrations today on how to turn on those screening reminders. This is being presented today because, as we noted, there are some clinics that, during the updates to iCare and RPMS during these last few years, some screening tools inadvertently got turned off. And so James and Kristen are here to talk about the importance of turning these on, keeping these on, and how EHR can support your HCV programs in your clinic. So James, I'm going to turn it over to you.
Excellent. Well, my name is James Blaine. I'm an improvement advisor, quality improvement advisor from the Institute of Healthcare Improvement. I also am a clinical applications coordinator and a HIM and 3 other things. And you wear in our small communities, you wear multiple hats. But I've got the pleasure of traveling all over the country, working with 65 or so different tribes in my last 15 years. And, really working with setting up and building programs and improving programs and, using the tools that we have. And that's a lot of the clinical applications coordination. And that's what I'm going to talk a little bit about today. I'm going to ask Kristen to share her screen, and then she could start to pull up some of these tools. And I'll just kind of go, we can lap back around and we can do one-off or, whatever they call it, sidebar technical trainings and stuff like that. You can reach out to me at any time, unless I'm on an airplane. And we can do this one-on-one, but I'm just going to kind of show you the basis so you guys kind of have a big idea of what it kind of looks like. So the first thing we'll show you in here after we pull this up is the multiple different places you can find your clinical reminders. So right here, when you look at your electronic health record and you open it up for the first time, you're going to see that clinical decision support tool at the top as a red clock. That red clock is telling me that something is due on this patient, this demo patient. So go ahead and click that. And then in here, because they're demo patients and we give them every disease, they're 4 years old, pregnant, and male or something. It doesn't make any sense at all because we're just giving them all these diagnoses and see if we get these things to work. What we're doing is we're looking real quick and all evaluated to make sure that we have the Hep C on here. Are we showing up the Hep C? There it is. So we have it. Okay, so if you don't have this, you're going to have to load it. So the next thing we're going to do is look at, actually stay in here, Kristen. From here, we're going to go look at where it's at and how to arrow it over in our system. So we can go to Action, Edit, Cover Sheet. So this is basically the configuration component of the electronic health records for reminders. And what this is doing is saying on the top left, the top panel, we have all the ones that are loaded onto our system. If it is not loaded on our system, we're going to show you how. So there's a little button that says System, and she's going to go ahead and click on it. So all the ones on the left are the ones we can load onto the electronic health record. So what you would do is on that left-hand panel, you would scroll down and find the Hep C, and she'll go ahead and highlight it, and then you hit that little arrow and go ahead, and what it'll basically say is, hey, you guys are already loaded this. So that's the first step. So you got to have a clinical applications coordinator or somebody with those keys, like a site manager or an IT person, go in and arrow that over, say, hey, we're going to start using this. Okay, so now let's say that that is not in there. We're going to show you real quick where that lives in the background and these patches that are coming through. So she's going to go ahead and pull up an RPMS session, if you will, and we're going to go into the configuration of your clinical reminders, and I'll show you the reminder exchange and then how you would actually install that. So this is one thing that when I go around the country, a lot of places I go to, like I'm talking 50% of the places I go to have a lot of the ones that Brig and Jessica and those guys care about, like they have like syphilis or chlamydia or Hep C or HIV on the sideline. They're not even installed. And I'm like, no, we got to get these out. We got to get these out. This is the new recommendations. So we're going to go into BEH. We're going to go into the configuration menu for clinical applications coordinators. And we're going to go into REM. So all reminder configuration, even copying of reminders. So like what we'll do sometimes is we'll go in here, copy an existing reminder like colon cancer. When it's set at 50, it's now 45. But sometimes sites want to start screening at 40. So we'll just copy it and we'll change the age range or the frequency. So we have a tremendous amount of power just utilizing these clinical decision support tools. And we can kind of customize them to fit our specific region, our specific area of what's going on in that area. Okay. So from in here, we're going to go into the exchange. So EXC, and then enter. And here are all the reminders that we can install on our system. So I'll just have her kind of arrow through so you guys can see how many there are. So if you're a provider and you're seeing this, you're like, I didn't know we can load all these things. Yeah, I want that one. So really, if you're a good clinical applications coordinator, or you should be sitting down with your provider saying, here's all what we have available. Is there anything that catches your eye that you want? So now we'll go down and we'll kind of get to that Hep C one. And we have another one that's called a screening bundle that is tremendously popular. And we've been using that all over the country and messing with that one. So here we have some of these. You see the HIV screen, you see the HPV screen, you see the Hep C screen. Here, all I would do is go 85. And then what it does is it automatically takes you to the install button. We're not going to install it because it will override everything. And you just kind of hit enter here. And then it'll pop into the dialog one. It'll say dialog at the top because you've installed the logic. The next screen, you just say IA, install all. And there'll be one section where you get to a lab test, LRZ, which is the lab mnemonic. And you just put in the name of your Hep C lab test right there. And that makes it so you can order it from the dialog. So now, let's say we went in, we installed it. It's now going to show up on the EHR in that little red configuration box, and we're going to arrow it over. And now what we're going to do is we're going to go take a look at what it looks like and where it is. So these tools, coupled with some of the stuff that came out during the pandemic and tools like iCare, are putting us into a very, very extremely powerful position. For the first time in the history of medicine, we know who, what, where, when, and why, and we know how to target them, and we know how to communicate with them. All right, so now we'll open up the electronic health record, and I'll kind of show you all the places where it lives. So we have it there first. The second place is you normally have like some kind of cover sheet or a review tab in EHR, and a lot of times it's on there. And I don't know where that lives for you guys. Here it is. Recent encounters is what they called it. So in here, you're kind of looking at what are all the reminders that is due for this patient. So this is the second place we can see it. What are their adverse reactions? What medications are they on? Recent visits, etc. So we got the clock. Now we have it in a review tab. So the EHR is telling us, hey, this is what this patient's due for. Let's do this. So now we'll go into the notes tab, and I'll show you what it kind of looks like as the dialogue itself. And then just to let you know, we can manipulate these dialogues. So if we're in a special area and we're just trying to do something at a different age, or we want to make sure we're doing everybody at a younger age, or put in other screening questions, we can do that. So she's going to start a new note. So all of this is built off of a note. You got to be in a note because that's the best place to do it. Most productive place to do it. And what she's going to do is once you select a new note title, you see how on the bottom left you get reminders. We now can go into the reminders. We can find that reminder and we can double click on it and do it. So she's now going to open it up, and this reminder, probably because we're messing around the install, does not have the dialogue connected to it. So Kristen, I don't know if you can go in and go look at it and connect it and do it, or if that's worth the time, but basically it says, this patient is due for Hep C, go ahead and order the test right here. And it literally connects to your lab, and you send the patient to the lab and they start that process. So the other thing I want everyone to think about is the other tools that we have available to us is pick lists. We can basically build pick lists in the E&M codes, and then we can add all of our disease-specific pick list items in there, like procedures and CPTs. We can also create pick lists in ICD-10. So in the IPL, we call it, in the IPL, you can create a specific disease-specific pick list that have also care plans, have visit instructions, and have treatment plans built into it. And so if you have a patient who you have diagnosed with Hep C, you can actually use that IPL to add constantly to that note. So it will basically go look at that past care plan and it'll add it to your note and it'll keep adding. So you can say, 2 weeks ago, we talked to you about this. This week, we're going to want to do this for the treatment plan. Then we're going to want, and it'll build and build upon that. One of the final things I would talk to you about is quick notes. Kristen can kind of probably click on up there to show you. So what a quick note does is it ties a note title in with an EHR dialogue or template and brings it all up from anywhere in the EHR. So she could be way over in triage, and then she can hit this quick note button, and like, so she pulls up her screening tool. I'll kind of show you what that looks like.
Kristen,
And
can
you
you
should-
hover back over the quick note tool?
Yeah, it's that little Excel spreadsheet with a pencil on it, is how I describe it.
Perfect.
So
Thank you.
now you probably have one for a nurse screening bundle, right? Screening bundle. So what this will do is it just changed her note title for her. It gave her a new note title called screening bundle, and it's automatically pulling in whatever we put on this screening bundle. So right now we have, a couple of the vital signs because we want the MAs to go in and start doing all this stuff. So they're screening the patients. We can put a whole section like San Carlos Apache has a whole section on here that is the top part is the nurses and MAs, and then the bottom part is the providers. They have fall risk assessment. They have a lot of mandatory stuff, and that's probably going to be like one of the last things I kind of lead off on. But we can put the Hep C right into here. Now, where a lot of this is driven from is policy and procedure. The people that I've seen that are successful all over the country, out of all the tribes I've worked with, they literally just put it into a policy and it's now business as usual. So what they say is every time a patient comes in, for example, at San Carlos, because there are high rates of diabetes, every time the patient comes in, we're going to do a blood stick. Every time we're going to screen for Rocky Mountain spotted fever. And they make it a policy that drives the care that they drive instead of just saying, oh, well, I didn't think they needed it kind of thing. So this comes from either like their health board or their tribal council will say, no, we're going to make this a policy and we're going to do this at every visit. So if you want to drive things like HIV screening rates and Hep C screening rates, look at going to policy first and then kind of coming back to, all right, it's got the blessing. We're going to do this for everybody. Finally, to wrap it up, now that we have all this stuff and now that what do you do with it, right? So we're seeing patients, we have the little red clock saying, hey, this person's due. We have options to quickly knock them out, send them to the lab. Now, what do we do when we come back with what we call a finding? So I'll take a look at that in iCare and just show you a couple of things in there. So I'll have our lovely driver open that up. Thank you for doing all the hard work. So in here, this is iCare, and these are all our panels. And I'm just going to kind of show you quickly how we can make a panel for like just Hep C. And I do this all the time because they'll come up and ask me specific questions, like Jessica, when it was where we learned this the first time, where she's like, tell me all the people have Hep C. So let's go in here and we'll go new. And we're going to create kind of what you call, give it a good name, maybe call it Hep C test demo or something. You got to have a name to go forward here. And then what we'll do is we'll do an ad hoc search. And then we'll go to PCC. And then we're going to base it off of lab tests. Now, these would be tests that are in your lab. A little Traverse Bay band is a little bit smaller, so I don't know what lab you would associate this test with. But at bigger places where you have more of a stronger, robust lab, you're definitely going to know the names of your labs. So what we'll do is we'll do it by a time frame. And then we'll do like the last year or 6 months or whatever. There you go. And now that we have that, we can search for the lab test itself. Now this is where Kristen might know what the name of that is. I have no idea. So there, we'll just do that P for a reference lab, or you got another one. Okay. So now what we're going to do is we're going to actually create a panel of all the patients who have had this test. We also have a little bit more strength here because what we could do is we can also edit for a lab balance, or a value, right? So we do this a lot with A1Cs. We say, show me everybody over 6 or something. Show me everybody over, and we create that list. That means they have a test with that certain value. Okay, so now she would go okay, and this would start to populate. So now I'm taking a population of about 3,000. I'm whittling it down to the folks who had a Hep C test reference lab, and also that test has been put back into the system. So I don't know if these guys are putting this back into the system or what they're doing with it, but let's see if we get a return on that. But the important part is I wanted you to see how I went in there, went to ad hoc, TCC, lab test.
James, while we're waiting for that to come up, we do have one question. I think this is a really timely to ask this to Brig and Dr. Cushman. This question is from Heidi Dumas. And what is the recommended screening for Hep? Do you recommend the clinics put in recommended screenings for all hepatitis or just Hep C? So in the screening reminder bundles.
There's a standard Hep C screening reminder that's been made. The universal screening reminder is for hepatitis C. Hopefully Hep B and A are covered by vaccination. So it's a Hep C. Your prenatal bundles are probably a little more comprehensive on viral hepatitis. And also some sites, I would say most now will do, when they do screen, it'll be an antibody and then if positive reflex to a confirmation. Because as we said, some people will clear the virus. So about 25% of the people will be antibody positive because they were exposed, but then they will have no virus. And so they do not need further clinical follow-up for Hep C. So did I answer the question or did I just completely go off track there?
Yeah.
That got it right? We're good.
When you, Brig, real quick, when you guys say screen everybody, what does that really mean? Does that mean everybody?
Yeah, the official recommendation is, I think 18 years and over, 18 to 70 or something like that. I have to look at the upper age limit, but it's starting from 18 years and over. And again, we don't do this mechanically. You don't just say on your 18th birthday, here's your screen and we're done forever. There's obviously very important clinical judgment on how maybe you want to do. I know some areas with very high burden have just started making it every 5 year because it made more sense to them. Or just, as you said, really put it on their differential diagnosis radar so that maybe testing people who are, more frequently as if they think there are risk factors.
Yeah, high risk factors. And I mean, I've also seen policies that were driven just by the community itself, where they said, no, we have high rates of like depression or we have high rates of domestic violence. So what we're going to do is screen those 4: alcohol, tobacco, depression, domestic violence per policy every visit. So because somebody can start drinking tomorrow, somebody can start smoking tomorrow, somebody can start, being abused tomorrow. And so it's funny because at these places they would walk in and they're like, I don't drink, I don't smoke, I feel safe in my home. Like the patient will actually say it. So again, going back to use policy to drive a lot of the changes you want to create. So this is taking a little bit longer. There's a little bit of glitch in the system.
So, some policies that you've mentioned have gotten, Nick saved me in the chat. It's 18 to 79 years of age. But places are getting a really high yield if they are able to implement screening in their tribal jails, behavioral health settings, and others too, besides primary care. All right, I'll be quiet now. Go ahead, James, you got it.
No, that's perfect. Yeah, San Carlos has got a jail team. That's all they do is go to the jail. All right.
So we have one more question, James, while you're waiting for this to spin up. So Heidi is concerned that they don't have a full-time CAC, and she knows there are many reminders that they don't have or don't have updates. Is there a way to CSET/print an entire list of options?
Yeah, you got me. So
yes.
You got Kristen. We can help you.
Heidi, we have James' email in the chat, and then also I will put my email in the chat, and we have EHR office hours every Wednesday at 1 p.m. Eastern time, and we can support you in any way, shape, or form there too. So I will put my email and James' emails in the chat. Please feel free to reach out, or you can even put yours and we will reach out to you.
So if you guys look at the top of this, so instead of messing with this panel, this is how you would normally do it. Sometimes you guys are at the witching hour right now with your area, which means it's the end of the day, so it's being a little taxed. So what we're going to do is we're going to go up to CMET at the top. That means care management event tracking. So in our demo database, what we can do is if you kind of look at the top left, you have a couple of categories you could sort by. We can actually sort by disease, like a domain, right? So we can sort by liver, for example. So we're going to add liver. We can take off the other ones. And then what we're going to do is this is literally looking for events. So this is looking for people in the last 3 months who had an event, meaning a test. So we can change that time range to like a year. And we'll kind of get an idea of what the patients who have events that we can actually start to say, all right, we're going to track this patient. So if you're a more Philly, and then Chris, scroll over to the right a little bit so you can see if they have the results sometimes. So they have result date, they have expanded result, what current status resulted, non-reactive. I can literally right here filter for, show me all the people who are reactive. Now I'm going to start tracking this, and I want these people to come back, in this time frame. So if you look up here, you see there's a track, don't track, and add manual event, batch process. There's a whole bunch of stuff. So I can pick the patients I want to track, and now I have a special little thing saying these are all the patients on my list that went out, got the test, they had kind of a positive result, and now we are tracking them and managing from this panel. And this takes a matter of seconds. So I just wanted to kind of highlight a little bit of the strength. By using these in concert with clinical reminders, you can go out, and this goes even past this. This goes to like, we can create letters, we can take an Excel spreadsheet, we can start calling them to come in. We can use tools like audio care, use tool like care message, and quickly send them out a burst of messages like, hey, our records indicate that you're this age and you're at risk for blah, blah, blah. We've been doing this with COVID. We could start doing this with other disease domains. And that's what I kind of wanted to demonstrate a little bit here with Kristen is let's work smarter, not harder, and put these tools to use. So if you need one-on-one help and you want me to take a look and brush over what you got and make some recommendations, I have no problem doing that in office hours or no problem doing that one-on-one. Like I said, you could reach out to me and we can do exactly what we're doing here. We're sharing screens and I can just take a look. All right,
Well,
that's about it.
Does anyone else have any questions either for Dr. Cushman, for Brig, James, or Kristen?
I'll just put in a plug that, as Nick said, it just starts with that, getting that panel and then getting that first patient going and getting comfortable with the drug procurement and the treatment. These things are so effective. I think you get that first patient cured, and what we've heard from sites, like it's a real rush. There's very few things now that we can really say you're cured now, right? We're done. But this is a cure, and it really helps patients really turn the page and kind of get a win. So I think both for clinician satisfaction and for patients, it's a biggie. I know I heard from one clinical pharmacist treating that giving those results that, were completed treatment as there and you're cured is always there's tears every time for both of them.
And the other thing is, think of how many people are walking around in your communities right now that don't know because we haven't screened. And this whole process to being cured happens with, oh, let's screen them. Let's start there. They're coming through. We have an opportunity. We can identify who. Let's get them screened.
Thank you, James. That's the best message to carry forward as we close out today's webinar. This is a recorded webinar, so we will make this available to you and everyone else via email and also on the National Native Network website, which is keepitsacred.org. I want to again thank Brig Riley, Dr. Cushman, Dr. Chu, James, and Kristen. It takes a team to ensure that we have our healthy communities, and it starts when our first contact with our patients. So I want to encourage you all to engage with your clinics, engage with your communities, and have a safe and comfortable day here today. Thank you again for joining us. Thank you for our panelists, and thank you to Mr. Mike Willett from the National Native Network for making this possible.
Thanks.
Thanks, everyone. Have a great evening.